Let me also, to build on that, this is a two-way street. So information in the nervous system doesn't just flow up to the brain, but the brain has a remarkable capacity to temper our perception of pain. So, soldiers in the heat of battle can get catastrophic injuries and not notice much pain at the time. Or the gazelle that's being attacked by the lion can ignore its pain and run away. And the reason for that is that there's a very strong endogenous system that starts up in the brain and goes down through a number of way stations to reach the spinal cord, where it can interfere with the signaling between the primary afferent neurons and the spinal cord projection neurons. This descending modulatory pathway is very important. It is acting essentially as a gatekeeper to dictate how much pain we're going to feel. And it's actually this pathway that's the site of action of a number of analgesics like opioid drugs. And you'll hear a lot more about opioid action from Dr. Raj's talk later on in the day. So, in terms of understanding the basic science of pain, what are some of the fundamental questions that we're most interested in? Well, this is a partial list that tells you a little bit about how we approach this problem. First of all, we'd like to know what are the molecules within these primary afferent nociceptors that allow us to sense and discriminate among painful versus non-painful stimuli. And one of the lessons that's emerged over the last 15 years or so is that many of the molecules that are particularly involved in detecting noxious chemical and thermal and mechanical stimuli are either very specifically expressed in nociceptors, or at least they're very much enriched in those neurons. And this presents both an opportunity to understand why certain stimuli might cause pain, but it also offers an opportunity, because if one can interfere with the function of those molecules, you might be able to target pain without having adverse side effects on other parts of the body. Also, as both I discussed and Paul Fuchs discussed earlier, sensory neurons involved in painful and non-painful stimuli are quite heterogeneous. And even within the population of neurons that we describe as nociceptors, as neurons that trigger the perception of pain, there's a substantial amount of heterogeneity. Not all pain-sensing neurons are created equally. And in fact, understanding which particular subpopulations of neurons are involved in, for example, mediating the perception of heat-evoked pain, or mechanically evoked pain, or chemically evoked pain, has turned out to be very important, because these neurons can be modulated independently from one another in various chronic pain states. It's also, and that gets us to the next point, and that is we'd like to understand when a patient makes this transition from acute pain, which is adaptive, to chronic pain, which is very maladaptive, what are the molecular and cellular changes that account for that transition? So, for example, which molecules that weren't expressed before in those neurons are now expressed? Or which molecules that were expressed before are either increased or decreased in their expression levels? Are there changes in activity of the existing molecules? So, for example, certain molecules in these sensory neurons can be modified by phosphorylation, and that can make the neuron either more or less sensitive to noxious stimuli. And finally, it's not just the molecules in these neurons that change, but the anatomy of these neurons can change itself as well. So if you look at skin of an individual who's experienced inflammation or neuropathic insult, you see that the nerve endings actually get rearranged, and you get different proportions of different neuronal populations. And it's just like in real estate, location, location, location. Where a nerve ending is can have a lot to do with what its function is. Not all the changes that are important for the perception of pain are confined to our peripheral tissues. In fact, there's a lot of learning and plasticity that goes on within the spinal cord and within the brain that can change our perception of pain. And we'd like to understand what those events are. And then finally, this is a topic I'll mention briefly at the end, and that is how do non-neuronal cells like glia or immune cells or keratinocytes of the skin, these are cells that live and breathe around these sensory neurons, and it turns out that they can influence the perception of pain as well. We like to understand which ones are doing it and how. Okay. So just to get you into a little bit of specific information, one of the ways in which we've learned something about the specialness of nociceptive neurons and how it is that they carry out their function is by taking advantage of what I like to call a little gift from Mother Nature, and that's this greasy little molecule here called capsaicin. And as many of you may know, capsaicin is the pungent ingredient that you find in hot chili peppers or habanero or Scotch bonnet peppers like we see here. In fact, different strains of pepper express different levels of capsaicin, and as a result, they can be more and more painful when we bite into them. So a guy by the name of Wilbur Scoville back in the 1920s and 30s came up with this scale where he could take extracts of particular peppers, drop them on the tongue of a volunteer, I think they were volunteers, and ask them, how much, and basically ask, how much can you dilute that extract and still have the person feel pain? And so you can come up with a scale here that's actually proportionate to the amount of capsaicin that you find in the peppers. Now, capsaicin is a little bit of a double-edged sword. And what I mean by that is that if you bite into spicy foods or you're acutely exposed to capsaicin, you accidentally rub some in your eye, it burns like crazy. But protracted exposure to capsaicin can actually desensitize nociceptors. In humans, if you inject capsaicin into the skin, within hours to a couple of days, you can actually cause the nerve endings in the skin to regress. And it can take a few weeks for them to grow back. And that's in fact exploited in some over-the-counter preparations of capsaicin that's applied topically to the skin. So how does capsaicin cause pain? Well, this is an area that my colleague... Yeah,
I'm sorry to interrupt you.
Yeah, please.
Why would you butter that ointment? Why would you put...
Oh, I'm sorry. So let me clarify. So I'm not advocating its use here. Let me emphasize that first of all. This is not a clinical presentation, but basically the notion is as follows. If you have chronic pain, so for example, patients who have rheumatoid arthritis, very often it's difficult to find therapies that will control that pain. But one strategy that's been used is to apply high doses of capsaicin cream directly to the skin in the affected area. And the idea is that the capsaicin cream it'll initially excite the nociceptors, so you'll feel intense pain. But over time, over hours to a day, the nerve endings in your skin get so loaded with calcium ions that's toxic to them, and they end up dying back. And as a result of that reduction in functional nerve endings in the skin, patients get some period of relief. And it may take several weeks for those nerve endings to grow back to the point where one feels pain again. So that's the theory behind how this is working.
Thank you.
So we'd like to understand how it is that capsaicin works, and this is some work that my colleagues and I got involved with now almost 15 years ago.